Patients with myeloma continue to have disease relapse despite all the new therapies that we have developed over the past decade. So it's important to continue to develop new classes of drugs for patients with relapsed disease. Importantly, have a better understanding of the heterogeneity in multiple myeloma. We understand that this is a it's a group of diseases with a very similar clinical presentations, but have very different outcomes based on some underlying differences, primarily genomic differences. So I think it's important also for us to start focusing on developing therapies for high-risk multiple myeloma, especially patients with high-risk genetic abnormalities, but also patients with plasma cell leukemia, extramedullary disease, and so forth. So the unmet needs right now is continuing to get new drugs for the relapsed refractory patients and developing new approaches, whether it be new drugs or better combination of existing drugs for patients with high-risk disease. So we have a better understanding of the disease biology, especially the genomic sequencing studies that have been done over the past few years have given a better sense of the mutational landscape in myeloma. I think that definitely offers a plethora of targets that we could potentially adapt for developing new therapies. And there are clinical trials that are being developed looking at targeted agents for specific mutations, for example, MEK inhibitors in patients with RAS mutations, which are very common in myeloma. So we are trying to now see whether we can take these targeted agents and combine those with the standard combinations to see if we can make a difference for the genomically abnormal myeloma or the mutated myelomas. In addition, there are signaling pathways which we know are very important for myeloma cell survival within the context of bone marrow microenvironment. So we're also starting to look at some of these signaling target drugs, which, for example, the PI3 kinase inhibitors have shown some activity. A couple of other very exciting targets which seems to have some activity based on the recent clinical trials are one, the apoptotic pathways, and the other one is some of the nuclear transport proteins. The venetoclax is a targeted drug which is specifically designed to bind to BCL2, and the early clinical trials clearly show excellent activity, at least in a subgroup of patients that carry the 11-14 translocations. Similarly, selinexor is a XPO1 inhibitor which kind of traps many of the tumor suppressor proteins within the nucleus because of the nuclear transport protein inhibition. And that also seems to have efficacy as a single agent and is currently being studied in combinations. Finally, I think we also have a variety of different surface targets that we can go after, or cell surface targets we can go after, which includes the BCMA. So we have BCMA targeted CAR T cells, we have BCMA targeted antibodies which are conjugated to toxins, and also BCMA targeted BiTEs that are being developed. So I think there are different targets both on the cell surface, within the cell, that are being currently studied. In addition, I think the microenvironment is going to be very important, particularly the immune microenvironment. So I think agents which are targeted towards enhancing that anti-tumor immunity and also restoring some of that immune microenvironment is also going to play a key role in combination. So the ones which are very close to, I think, fruition are probably the BCL2 inhibitor venetoclax that is already in phase 3 trials. Selinexor is the XPO1 inhibitor that is also in clinical trials in combination with bortezomib. We have seen some very exciting data with the CAR T cells. We anticipate that's also going to hit the clinic in the next few years. We also have seen some monoclonal antibodies, especially ones that are targeted against the BCMA, and the early results with the GSK drug is also pretty promising, and we hope that will also reach the clinic in the next few years. So multiple therapeutic modalities have become available in the past few years for patients with relapsed disease. The most important, I think, has been the monoclonal antibodies. So daratumumab, which is directed against the CD38 on the myeloma cells, have been studied in combination with a variety of different drugs, both in phase 3 and phase 2 settings. And especially the combinations with the immunomodulatory drugs appear to be quite efficacious, and that certainly offers an opportunity for patients with relapsed disease. The other monoclonal antibody, which is elotuzumab, which is targeted against SLAMF7, has also been studied in combination with lenalidomide and pomalidomide as well as bortezomib, and that also appears to be quite efficacious. Now, there are also the next generation proteasome inhibitor like carfilzomib, the oral proteasome inhibitor like ixazomib. Both have been approved for use in combinations and also offers additional opportunities for the patients with relapsed disease. So most of the changes that have been incorporated into the latest NCCN guidelines relates to obviously the availability of some of the newer agents. But I think from a overall perspective of the NCCN guidelines, I think the treatments have been better organized in terms of some of the preferred therapies versus the other therapies which may be useful under certain circumstances. So I think instead of just giving a whole long list of different therapies, we have tried to organize them in terms of the best available data, especially from phase 3 trials, so we can make more categorical recommendations as to what you might want to use. And this has been incorporated into the myeloma guidelines, the amyloidosis, and the Waldenstrom's guidelines as well. And we have also factored in some of the cost of therapy as well in terms of developing some of the evidence blocks for the NCCN guidelines, which I think would be quite useful when you try to make decisions as to what regimen to go with.